If we go back now and we take a look at what the country needs, right? This is sort of where your 9,000, 10,000 foot view. We've talked about what patients need. We talked about a very focused attempt to get an individual patient on the correct therapy. Nationwide, what does the country need? What do patients need as a group that's right now not being met?
Yeah, good question, actually.
Why, thank you.
Yes. I think
Feel
one of the
better
things
now?
we discussed earlier was the need to really identify patients who are at risk earlier, and really address LDL levels before disease occurs, before primary prevention phase, so that we don't have this conundrum of very difficult to treat, very difficult to manage patients who are very, very expensive, regardless of how we manage them. And I think one of the unmet needs would be to be proactive in doing screenings earlier as part of preventive care, and then early treatment strategies for patients. So you say you have a great response with patients with lifestyle modifications for those who will respond, who are motivated.
Correct.
And becoming more engaged with patients early in the game, in their earlier years of life before we have to have tough conversations that are a lot more expensive.
The scenario is they come into the office and I don't talk to them about it. They go home and the wife says, or the husband says, so what did the doctor say to you about your weight and your exercise? We didn't talk about it, at which point it becomes unimportant. Because if it was important, I would have talked to you about it. And that's not what happens. So you got to bring it up, period. And in doing so, you can gauge their degree of interest. If they look at you like they'd rather be boiled in hot oil, then you stop the conversation. But otherwise, you keep going with it.
And that's a national tragedy that we have.
What is?
20 or so % of Americans smoke cigarettes.
Is it that high still? I didn't know the actual number.
I think it's around 20%.
Is it?
Don't quote me, but I think it's in that neighborhood, which to me is inexcusable when we talk about cardiovascular mortality. I'm not sure that the relative contributions between lipids and cigarette smoking, but cigarette smoking certainly is a huge factor.
In this conversation, I just want to put this in perspective, where we have been talking about these targeting agents to drop your cholesterol, drop your heart disease risk. We have a problem in America with 20% still smoking. What's the 900-pound gorilla on the table here, yeah? No?
Lifestyle.
I would think so, right? So there's an unmet need, you think? Okay, so what is the future now of cholesterol management? I'm going to broaden this out. What does the future of heart attack risk management look like in this country going forward?
Well, it depends whether we have free reign or not. Whether doctors
He's not going to give you free reign.
Free reign to do what the FDA has. She might actually.
See, he's not that threatening. It's
right,
okay.
to do what the FDA has already mandated in the PIs. The view is very, very optimistic actually. We have the capacity to lower people's LDL to unprecedented levels. This will reduce heart disease dramatically if we can use these agents. And I think we can make an enormous dent in heart attack, stroke, and death, and really change the playing field.
It's not free.
Yeah, and I don't disagree with that. But given enough money, we can do just about anything that we want. And that's the real question. It's a societal issue, a financial issue, a governmental issue of how best to use our resources. And if resources are unlimited, yes, we can do more than what we're doing now.
Have people bought into this? Has the government bought into this? That we can really do this? We can really strike at the, you'll forgive the expression, at the heart of the heart disease issue? Do you see a buy-in at the federal level?
I would say not yet.
How long is it going to take? I mean, 800,000 deaths last year?
Yeah.
That's a lot of people.
They stopped voting, my understanding is.
I mean,
Not
how many
all of them.
747s is there?
Right.
It's a lot.
Right, it's a lot. And what I look at it is that with the advent of PCSK9s, there's a lot less maneuvering to get cholesterol down. And you can take this time to focus on obesity and blood pressure and maybe do a little better job with those.
So it takes the pressure off.
Exactly right. And what this does is allows you to get at the big three, that when you get a better handle, you can really reduce cardiovascular disease.
We touched on this peripherally before about earlier prevention, earlier drug therapy. What we haven't talked about is the use of the PCSK9s in primary prevention. What do you do with the 30-year-old individual who comes into the office, is perfectly healthy, has a cholesterol LDL of 130. We know that 30 is better than 130 long term. You put them on a statin, they agree to take the statin, it goes down to 70, but we know that 30 is better than 70. So do we put somebody who's 30 years old on a very expensive drug for the remainder of their life to reduce that cardiovascular risk?
I'll add one more wrinkle to that.
Okay.
Would you, as a patient, rather be on a statin with its side effect profile for the rest of your life, or on one of these newer injectables with a much better side effect profile for the rest of your life? Damn the torpedoes, full speed.
Well, of course.
And this is the main issue, because I firmly agree with this, because the amount of the impact of early cardiovascular disease is huge. And you could start this out so you get success. Start with the people with family histories. Start with the people who look like Mr. Potato Head initially, with big bellies, and go after them first to see what you can do. If you get some success with early treatment, you generalize it to more of the population. But I agree completely. Statins also have baggage. Google the word statins. I promise you what you come back with is nothing glowing. It comes back with all the horrible stories about how they make you stupid, give you diabetes, all of which is really not necessarily correct. So I think that these drugs have nothing bad to say, except they're expensive.
And you know what? At that moment, we've all said kumbaya. I'm going to stop for just a moment, because this is a good place. First of all, I want to thank all of you for being here. It's been a tremendous discussion. It's been wide-ranging and good-natured, which is not bad when we have both insurance and practitioners at the same table. But a very interesting discussion on some really promising new agents, and you've brought some tremendous and interesting detail to this and some texture to this. But in the time we have remaining, I want to give each of you one last opportunity to have your last final say. Dr. Baum, you have the first shot.
Okay. I guess to conclude this kind of conversation, I would say that since access is such an important aspect of this entire discussion, that the patient needs to get involved, that the patient has the loudest voice, and the patient needs to understand this. If the patient is denied a therapeutic that a doctor has prescribed, the patient needs to contact the insurance company, and that will have impact. And I think if I can get that one message across, then that would be valuable.
Dr. Strohecker.
I think my final statements to our discussion today would be that really what I see in the practice that I am involved in today is that patients aren't really getting their maximal value out of proven medications, statin therapy, as well as lifestyle modifications. I think we can all do a better job at helping to get more patients on the right kinds of therapy. And then when we're able to do this, it's exciting to think about the other options that are out there that can really help patients have better outcomes.
Dr. Johnson.
Yeah, I guess my feeling on this is that there's more common ground than there is adversity, and it's oftentimes portrayed as a us against them type of situation. I don't really think that's the case. And I certainly agree that the patient needs to get more involved, both with their responsibilities and obligations to reduce cardiovascular events. But yeah, I think the future is bright.
All right, and Dr. Weintraub, you've got the last word.
I agree that it should be a partnership between the patient and his physician or her physician. And I think that way there is a better dialogue towards helping them understand what they're getting treated for. They would then perhaps have more of a buy-in. So any either lifestyle changes or medicines, they'll be more likely to adhere to. And then when it comes time to dig your heels in and put up a good fight to get what they need, they do so with you. And many times there is a louder voice, as has been said already, when the patient speaks up.
All right, I want to thank you all again. Tremendous discussion, wonderful guests. And I want to thank you, of course, for joining us as well. On behalf of our panel, I want to thank you for joining us, and I hope that you found this AJMC Peer Exchange to be informative. I'm Dr. Peter Salgo, and I'll see you next time.